So my topic is about desidustat and chronic kidney disease. Now I'll be covering points about in the introduction, the pathophysiology of anemia and CKD, the efficacy and safety of desidustat, real-world experiences of desidustat from the presentations from ASN Kidney Week 2024. I will also speak on what the guidelines say about desidustat, and then we'll conclude the session. So we have come a long way in the treatment of anemia, evolving from blood transfusions in the early 1950s to iron therapy in the late 50s and ESAs in the early 90s. And now we have a new kid on the block called desidustat, which is a HIF-PHI, that is hypoxia-inducible factor prolyl hydroxylase inhibitor. So desidustat is an orally bioavailable HIF-PHI. It was approved in India in March 2022 for anemia associated with dialysis-dependent as well as non-dialysis-dependent CKD. It is also in clinical development in other countries like China for the treatment of anemia in CKD, in Mexico for COVID-19 infections, and in USA for the treatment of chemotherapy-induced anemia. So before we talk more about desidustat, let's understand more about anemia and CKD. So the pathophysiology of anemia and CKD is multifactorial. As you can see, blood loss occurs directly during hemodialysis. CKD itself is a state of chronic inflammation, which can increase hepcidin levels and can lead to iron deficiency. And then uremic toxins can shorten RBC lifespan. And then, of course, with kidney failure, there's decreased production of erythropoietin. And so all these things together cause and exacerbate anemia as chronic kidney disease continues to progress. What happens to EPO production in CKD? So in CKD, EPO deficiency starts very early, right from about stage 2 to stage 3. Severe deficiency occurs when GFR falls to below 30. Absolute EPO deficiency occurs either due to decrease in EPO production itself or due to errors in EPO sensing. CKD causes an alteration in oxygen delivery to kidneys due to reduced blood flow. CKD results in adaptation of renal tissues to consume less oxygen, leading to maintenance of normal tissue oxygen gradient despite decrease in blood flow. Consequently, the PHT enzymes continue to remain active, and the HIF heterodimer, which is necessary for the production of EPO, does not form in CKD. Now, let's understand the burden of anemia. So this is a study published in Kidney Medicine Journal in 2022. It shows the burden of anemia not only on patients, but also their caregivers. So the work productivity impairment was seen in 45% of patients with CKD and anemia. Also, the burden on caregiver was higher in those with CKD patients with anemia to the tune of around 69%. Now, more about hypoxia-inducible factor. So it all started in 1995 when Greg Sebetsa identified the HIF, or hypoxia-inducible factor. 6 years later, William Keelan and Peter Radcliffe independently identified prolyl hydroxylases, which degraded HIF. These gentlemen were awarded Nobel Prize in 2019. So let's try to understand how the HIF pathway works. So all cells of our body produce hypoxia-inducible factor. Under normal conditions, that is under normoxic conditions, prolyl hydroxylase degrades HIF alpha. Now in hypoxia, whether it is due to anemia or due to decreased oxygen delivery to the tissues, these prolyl hydroxylases are inhibited and HIF alpha is not degraded. And this HIF alpha combines with HIF beta in the nucleus of the cell and binds the entire complex bind to hypoxia responsive elements, or HREs, in the DNA, activating transcription of genes involved in erythropoiesis, angiogenesis, glycolysis, and other metabolic adaptations.
Dr. Jaison, sorry to interrupt. Sir, can you make the slide full screen? Because next slide is showing up right now. It is into the part presentation. Can you make it full screen?
Yeah.
Jaison, click on slideshow, and when you are
Is it okay now?
Yeah,
Yes,
it's
sir.
fine. It's
Done,
fine.
done.
You can see the whole screen, right?
Yeah.
Yes, yes.
Yeah. Thank you. Okay. So, yeah. So this is how the HIF pathway works. Now, there's a coordination between APO and iron. So it's also interesting note that in addition to improvement in erythropoietin production, HIF-PHIs also stimulate proteins involved in iron mobilization. So there's more iron released from the storage tissues. Thus increasing APO production, increasing iron transport and mobilization, increasing mobilization from body stores, and absorption from the GI tract. Indirectly, there is also decrease in hepcidin production, which further helps in iron mobilization. Now, this is particularly important in our patients with CKD, as very often there is restricted erythropoiesis and iron is always locked away in storage tissues and can't be absorbed normally from diet or oral supplements. Now, what led to an interest in HIF-PHIs? So HIF-PHIs are oral agent. This itself is a matter of convenience for many people, especially those people not on dialysis. And there are also safety concerns with traditional ESAs, which also led to an interest in HIF-PHIs. Now, are HIF-PHIs safer than traditional ESAs? That we will see in the coming slides. There are other potential benefits like improved iron availability. HIF-PHIs were also found to work even in the presence of inflammation, unlike the normal erythropoietins, the ESAs. There are also situations like ESA hyporesponsiveness, in which HIF-PHIs are found to be useful. Now, what is ESA hyporesponsiveness? According to the European Best Practice Guidelines, it is defined as failure to achieve target hemoglobin levels, that is 11 to 12 grams per deciliter, with doses lower than 300 units per kg per week of epoetin, or 1.5 micrograms per kg per week of darbepoetin alpha. So there are multiple causes for hyporesponsiveness of ESAs. It can be inadequate dialysis, pure red cell aplasias, thyroid dysfunctions, vitamin B12 folate deficiencies, non-compliance, aluminum intoxications, hyperparathyroidism. But the major cause is inflammation or infection. Now, around 10 to 20% of patients with anemia and CKD do not respond optimally to ESA treatment and are unable to achieve the targeted hemoglobin concentration or require high ESA doses to do so. So this is the data from the DOP study showing that 3 months after hemodialysis, patients experience new inflammation. And in such patients, hemoglobin levels declined and dose requirement of ESAs went up in those patients who had some kind of inflammation. So now, what happens when ESA dose goes up? So this is a meta-analysis of various randomized studies published in AJKD regarding ESA dose and mortality. So here on the x-axis, we have hematocrit values, and on the y-axis, we have number of deaths. And on z-axis, we have the doses of ESA. So initially, higher hematocrit values actually lowered the number of deaths, if you see in these lines. So hence, eventually, patients were targeted to have higher hematocrit levels. And there were studies which targeted higher hematocrit values. And then it was found that the groups which are targeted for higher hematocrit values had higher mortality. When they analyzed further upon this, they found that it was not just the hematocrit value. It was basically the dose of ESA that mattered. So here, if we look at the Z axis, we find that at any hematocrit value, higher the dose of ESA, greater is the risk of death. So this raised a question whether if we don't raise the ESA dose much, could the outcomes be better? Hence, FDA came with a label saying it is better to use lowest ESA dose to reduce the need for transfusions. This is one scenario where HIF-PHIs could be of use so as to decrease the ESA doses. These are the HIF-PHIs available in the market. So in the US, it is just Desidustat and Desidustat that is approved, and that too, these drugs are approved only in dialysis-dependent CKD patients. The drug which is available to us in India is Desidustat. So all these drugs act on prolyl hydroxylase domain enzymes. So basically, there are 3 isoforms of these enzymes: PHD1, 2, and 3. 2 is the main regulator of HIF activity in normoxemia. So Desidustat is a pan-PHD acting drug. So it acts on all the 3 PHDs. Now, the pharmacokinetic properties of HIF-PHIs. Daprodustat, vadadustat, and molidustat are given as once daily dose, while roxadustat and desidustat are given thrice weekly. Roxadustat has the longest half-life, while daprodustat has the shortest. So since desidustat has a long half-life, we give it thrice weekly. And also it acts on all the three enzymes, all the three isoforms of the enzymes. So the dosage of desidustat in dialysis-dependent patients, it is 100 milligram administered thrice weekly post-dialysis. In non-dialysis-dependent patients, we can divide them into ESA naive patients, that is those patients who have never been exposed to ESA. In such patients, you can give 100 milligram thrice weekly. When you switch from ESA to an HIF-PHI, we give 100, 125, or 150 milligram thrice weekly, depending on the previous dose of ESA, which I will show you in the next slide. Maintenance dose is based on hemoglobin levels assessed every 4 weeks with a maximum dose of 150 milligrams thrice weekly. It is also advised by the manufacturer that we should not consume any food 1 hour before and 2 hours after taking desidustat. So how to dose desidustat? The maintenance dosing. So monitor hemoglobin every 4 weeks. Now, if hemoglobin level is less than 11 and the increase in hemoglobin is less than 1, then increase the dose of desidustat. Now, if the level is more than 11 but less than 12, maintain the same dose. Now, if the increase in hemoglobin is from 1 to 2, then maintain the dose unless hemoglobin is between 11 to 12, in which case the dose has to be decreased. Now, if the hemoglobin level is more than 2, maintain the same dose unless hemoglobin is more than or equal to 11, in which case the dose again has to be decreased. If hemoglobin level is more than or equal to 12, then stop the treatment for 14 days and initiate one lower dose if hemoglobin is less than 11.5. Now, the table below shows desidustat doses when switching patients from various ESAs. So here I have given some values of epoetin, darbepoetin, and methyl polyethylene glycopoetin beta, which is Mircera. So here you can see the different values of ESAs, and accordingly we can convert those patients to desidustat in this manner. Now let's analyze the safety and efficacy of desidustat. So this is a study done on non-dialysis patients. This study was done in India. It is a multi-center trial called DREAM-ND study. So it's a phase 3 study in which desidustat was compared to darbepoetin subcutaneous injections in non-dialysis CKD patients. So the study involved 588 CKD patients not on dialysis. They were randomized into 1:1 manner. So the time to achieve target hemoglobin was comparable in the two arms, thus meeting the non-inferiority criteria for desidustat. The hemoglobin responders were significantly higher in the desidustat group compared to darbepoetin group. There is also statistically significant reduction in hepcidin levels and LDL cholesterol levels in the desidustat arm as compared to the darbepoetin arm. So to sum up, the safety profile of desidustat was not on dialysis. Now let's see the summary of global studies conducted on various HIF-PHIs in non-dialysis CKD patients. It can be observed that there is significantly higher increase in hemoglobin seen with HIF-PHIs compared to placebo. All HIF-PHIs are found to be non-inferior to ESAs in increasing hemoglobin. Difference in mean hemoglobin after treatment with HIF-PHIs has been found to be up to 2 grams per deciliter during the treatment period in about 28 to 52 weeks. Significant reduction was also seen in inflammatory parameters like hepcidin, and also significant reduction in cholesterol levels were seen. Now, regarding the cardiac and renal safety of HIF-PHIs, a meta-analysis of 23 RCTs involving 15,000 participants did not find any difference in the occurrence of cardiac or kidney-related events when compared to placebo or ESA groups. Now, when I say this, it is important to point out that there was some increase in non-dialysis major adverse cardiac events with roxadustat and daprodustat. This was mainly in the on-treatment analysis, and there was a failure to demonstrate non-inferiority for major adverse cardiovascular events with vadadustat. This was one reason why why Desidustat and Desidustat was not approved by FDA for non-dialysis CKD. This is also one reason why Roxadustat was not approved by FDA in both these populations. But meta-analysis generally indicated an acceptable cardiovascular safety profile, probably not much different than ESAs. Now, regarding the safety and efficacy in dialysis-dependent CKD patients for Desidustat, again, previously I told about the DREAM-ND study. So here I'm talking about the DREAM-D study conducted on dialysis patients. So here Desidustat was compared to epoetin alpha in 392 CKD patients on dialysis in the same 1:1 randomized control manner. So here too, the time to achieve target hemoglobin was faster in the Desidustat group. Hence, Desidustat was found to be superior here to epoetin alpha. The percentage of hemoglobin responders were also better in the Desidustat group. Like DREAM-ND trial, there was statistically significant reduction in hepcidin and LDL cholesterol in the Desidustat arm. Here too, the safety profile of Desidustat was comparable to epoetin alpha in CKD patients on dialysis. This is another meta-analysis of 13 global trials involving dialysis-dependent CKD patients. It was found that there was no difference in major adverse cardiac events between HIF-PHIs and ESAs, and no difference in all-cause mortality or cardiovascular mortality. There was moderate certainty evidence to show that there was no difference in acute MI, stroke, heart failure, or dialysis access thrombosis. Now, this was another derivative from the DREAM studies. So Desidustat in DREAM study was shown to have an impact on hepcidin levels, at least in non-dialysis dependent patient population, as shown in the left-hand side. This was a significant reduction. Here too, clinically, it was observed that there was a reduction, but then in dialysis patients, this reduction was not found to be statistically significant. But yet there was some reduction which was seen in this study. This is another meta-analysis of 26 RCTs with close to 25,000 participants, of which 605 were on dialysis. And as you see, HIF-PHIs were effective in correcting anemia on comparison with ESAs, with significant impact on iron metabolism. And none of this showed any significant safety signals as far as cancers or AV fistula thrombosis or incidence of major adverse cardiovascular events is concerned. Now, coming to real-world data on Desidustat, which was presented in the ASN Kidney Week 2024, which I was fortunate enough to attend. So these data again are from India, though these were presented at the ASN, because Desidustat is not approved in the US for anemia related to CKD. It is being in the US. Desidustat is in for clinical trials in chemotherapy-induced anemia, but not yet approved for anemia due to CKD. Now, this is a single-center trial which was presented at the ASN Kidney Week. This is a single-center prospective study by Dr. Dinesh Kullar and team from Max Hospitals, New Delhi. So this study involved 64 patients, of which 50% were on dialysis. And these patients were followed up by Dr. Dinesh and team for a period of 24 weeks. There is an ESA naive group as well as another group where ESA was switched to Desidustat. In the study, it was found that Desidustat led to a significant rise in hemoglobin levels in both ESA naive as well as ESA switched groups. Desidustat was also well tolerated in both the groups. Compliance was also found to be very good. This is another study presented at the ASN. This study is by Dr. Sambat Kumar and team from Tamil Nadu, involving 68 dialysis-dependent CKD population. Here it was observed that by 3 months of the study, there was more than 3 grams per deciliter rise in hemoglobin in the Desidustat group, with very few adverse events like mild hyperkalemia and vomiting. This is again another study from Punjab involving 58 dialysis patients who had close to 3 grams per deciliter rise in hemoglobin at the end of 1 year, again with no adverse events. Now, here we have another one from Maharashtra with 79 patients, of which 35% were on dialysis. There was significant improvement in hemoglobin levels in this study, again with no reported adverse events. This is another one from Bangalore conducted in Apollo Hospital by Dr. Kumar Narayana Arun and team. So this study included 85 patients on thrice weekly hemodialysis, and it showed a promising response in terms of improvement in hemoglobin levels. Now, this is another interesting study, which was again published in the Journal of American Society of Nephrology and was presented at the ASN Kidney Week. This was a study by Dr. Arvind Kanji from Bangalore. So this is regarding the use of Desidustat in post-transplant phase. So here we have an interesting case report. So this is the case of pure red cell aplasia in a 52-year-old deceased donor transplant recipient who did not respond to IVIG or modification of immunosuppression or blood transfusions and did not respond to ESS2. But he had a remarkable response by 1 month of starting Desidustat. His hemoglobin improved, and there was further improvement by about 4 months. To be precise, this gentleman was transplanted in March 2023. He developed anemia in May 2023 when his hemoglobin dropped to 5.8 from 9.3. He was diagnosed to have pure red cell aplasia. So this was in May 2023 when his hemoglobin went to 5.8. And in November 2023, his hemoglobin, in November 2023, he was started on Desidustat and his hemoglobin improved to 8.3. And again, the dose was further increased to about 400 milligrams per week. So after that, by about 3 to 4 months, by February, his hemoglobin went up to 11.1 and thereafter stabilized at 13 grams per deciliter. So this is one study which gives us hope that probably this molecule can be used in cases like pure red cell aplasia, about which we discussed last week. Now, this is now a few words regarding pleiotropic effects of HIF-PHIs. So regarding pleiotropic effects of HIF-PHIs, like I mentioned in the previous studies, it was found to be useful in reducing hepcidin levels, although the hepcidin reduction is not a direct effect, but an indirect effect. It was found that HIF-PHIs reduce LDL cholesterol. So they have also been shown to cause an improvement in iron metabolism in clinical trials. There is also a positive impact on glucose metabolism, some role in AKI, some protective role in AKI, acute kidney injury. But then this is just seen in preclinical trials. There was no clinical trials done to look at the validity of this particular effect. It is also controversial whether they increase the risk of cancers, cardiovascular risk, and risk of retinopathy. Perhaps only further real-world evidence is going to give us answer regarding the the effects on cancer development and progression. So again, regarding the concerns using HIF-PHIs for treatment of renal anemia, this is a paper published in Clinical Kidney Journal by Takeshi and group. So the certain concerns were thromboembolism, vascular calcifications, heart failure, carcinoma, diabetic retinopathy, growth of cysts in ADPKD. So regarding thromboembolism, there were some incidents. The clinical trials did not show any incidents of thromboembolism, but then certain one of the studies with roxadustat showed that there might be some increase in AV fistula thrombosis. And regarding heart failure, roxadustat did show some increase in adverse cardiac events, but the other PHIs did not show much of an effect. Roxadustat showed to some extent. Vadadustat also showed some concerns regarding the development of adverse cardiac events. But then this was only in on-treatment analysis statistics. So this is still a gray area because meta-analysis does not show much cardiac issues. Now, regarding carcinoma, none of the clinical trials showed any incidence of malignancies, but theoretically, tumor cells also make use of hypoxic pathways, and then they lead to formation of vascular endothelial growth factors, which promote tumor angiogenesis. But then it's all theoretical. We have not seen in any of the clinical trials. But again, it is necessary that these things are long-term complications, so short-term trials will not tell us much. So this is something which we will have to keep looking in the post-marketing surveillance. So regarding the safety concerns, along with along with erythropoiesis, there is potential upregulation of several other hypoxia-sensitive genes. So, like I mentioned, the genes involved in angiogenesis, extracellular matrix production, cell proliferation, elevation of liver enzymes, and the fetal hepatic necrosis in a patient was seen in one of the trials, but it was not attributed to the drug. So, however, the other safety concern was hypertension, but then there was no increase in BP so far in any of the trials. In fact, there was some BP lowering effect in certain clinical studies. So it is also, so there is some concern of HIF2 pathway with pulmonary hypertension. This is something which has to be kept in mind. So people with pulmonary hypertension, pulmonary hypertension, this drug has to be used with some caution. No increase in VEGF levels or malignancies were seen in the doses which were used in clinical trials. So, like I mentioned before, small doses and short duration of clinical trials are insufficient to predict all possible side effects. Regarding anemia treatment and cancer, it is best to use caution in patients with active or recent malignancies, although none of the studies showed any malignant potential. Now, what do guidelines say? So this is the Asia Pacific Society of Nephrology guidelines. So to sum up what is mentioned here, it says that HIF-PHIs may be used after iron repletion in patients desiring oral treatment or in those patients with ESA hyporesponsiveness. Now, what does the UK Kidney Association say? So it's the UK Kidney Association guidelines say that HIF-PHIs may be considered after iron repletion in stages 3 to 5 CKD with anemia, so as to improve the quality of life and avoid transfusions. They also say that HIF-PHIs may be continued during acute illness unless there is a clear contraindication such as accelerated hypertension or thrombosis. HIF-PHIs may also be used in post-transplant anemia, as per UK Kidney Association guidelines. Now let's see what KDIGO says. These are KDIGO draft guidelines, not yet published. So this is under public review. These are going to be published in 2025. So they say that in people with anemia and CKD in whom correctable cause of anemia have been addressed, it is better to use ESA rather than HIF-PHI as a first-line therapy for treatment of anemia. Again, this is 2D evidence. So in patients with anemia and CKD, including those with ESA hyporesponsiveness, do not use ESAs and HIF-PHIs in combination. This is another guideline which is put forth by KDIGO 2025. But then again, there were studies where they have used ESA along with HIF-PHIs, a lower dose of HIF-PHI and a lower dose of ESA, and then they found that it was it had a good response in ESA hyporesponsiveness. But then KDIGO does not recommend this. Now, in patients with anemia and CKD, the hemoglobin thresholds for initiation and maintenance of HIF-PHIs are unknown, but it is reasonable to use the same hemoglobin thresholds as recommended or suggested for ESA therapy. Now, KDIGO recommends that HIF-PHIs may be avoided in some groups, like in those with active cancer or with a history of cancer in complete remission for at least 2 to 5 years. Those patients with polycystic kidney disease, because theoretically there is a chance of increase in cyst size, those with proliferative retinal disease, those with pulmonary arterial hypertension, and also those who are pregnant, because we do not have any data in pregnancy. And there is also concern for risk based on adverse event profiles in clinical trials, that is prior cardiovascular events, so that is stroke, myocardial infarction. So like I mentioned, in certain trials involving roxadustat and vadadustat, there was some increase in cardiovascular adverse events, but then meta-analysis say that it is safe, or at least as safe as ESAs as when we consider cardiovascular events. It is also, the KDIGO also says it is better to avoid in those patients with prior thromboembolic events, prior vascular access thrombosis, those with hepatic impairment, those with seizures, exfoliative dermatitis, hypothyroidism, bacterial infections, and sepsis. Because roxadustat was found to increase, was found to precipitate infections in one of the trials. But then again, it was not a there is no major rise in infection seen. There is insufficient data regarding post-kidney transplant anemia, but there is another trial involving Desidustat, where in post-transplant anemia, it was found to be better than ESAs. Yeah. And I showed another, just now I showed you another study by Dr. Arvind Kancha and team, where it was used for pure red cell aplasias. And then there is insufficient data again for use of PHIs in children. Now, I'm concluding my session here by giving you some take-home points. So oral route is definitely a convenient route, especially to those people who are not on dialysis and those people who are having needle phobias. So that's a plus point for this particular drug. And we also know that from the slides I presented, that it mobilizes iron and may reduce IV iron needs. So even in the trials, the IV iron requirement did come down with HIF-PHIs. So we will have to wait and watch as to how much of this is going to be translated into clinical aspects. And we also know that it works better in ESA hyper-responsive state. Now, we can't say that these HIF-PHIs are safer than ESAs, but safety are similar to ESAs. However, long-term surveillance from post-marketing data are of fundamental importance to definitely confirm the lack of safety signals. That's all about Desidustat. Thank you so much.
Jason, for that excellent presentation. So I'll be moving on to the case presentation, and after that we will be taking questions at the end. Now, this is a small case on treatment of refractory renal anemia with the Desidustat. The patient is a 65-year-old female, type 2 diabetes mellitus, systemic hypertension, mild renal dysfunction from 2012. It was presumed as diabetic kidney disease. In 2020, she was initiated on hemodialysis, was on twice-weekly hemodialysis initially, later increased to thrice weekly since last 1 year, and was on IV iron and EPO. She presented to us in 2024 with persistent anemia since 6 months, received multiple transfusions, and had persistent fatigue. Now, the patient was admitted and she was evaluated for anemia. Peripheral smear shown normochromic normocytic anemia. Reticulocyte count was low. Iron profile shown good iron levels with high ferritin. TSAT was 24, iron was 69, and TABC was low. Now, further investigations, beta-12 and folate were normal, ANA and C3-C4 were negative. USG abdomen shown bilateral small kidneys without any splenomegaly. Coombs test was negative. Evaluation for GA blood loss, there is no history of melena bar hematochezia. Stool local blood was negative. Upper GA endoscopy shown mild antral gastritis. Patient was managed with 3 units of PRBC. Dialysis prescription was optimized and continued on erythropoietin 4,000 units thrice weekly. Patient symptomatically improved and was discharged. She came for review after 3 weeks and patient had recurrence of tiredness. Hemoglobin again dropped to 6.2 and was readmitted and was given 2 units of PRBC. Hematology consultation was done, advised to repeat peripheral smear and iron profile. Almost same results, hence proceeded with bone marrow examination. Bone marrow shown marked decrease in erythroid cells, but normal granulocytic and megakaryocytic lineages. There was sufficient iron in the marrow with extracellular iron, and there is no ring sideroblast. Now, discussed with the hematology regarding the possibility of EPO antibody causing pure red cell aplasia, advised anti-EPO antibody and immunosuppression. However, the patient and bystanders were not willing for any further investigations because of financial constraints and other reasons. Then we had a thought to treat it with a therapeutic trial of Desidustat, and the patient was treated with some samples. These were the hematological parameters. When in 2023, it was somewhere in 11.7. Initial presentation in May, it was 6.2. And after 3 transfusions, it has gone to 9.1. And again, when they came for review, it was again 6.9. Now, after 2 transfusions, it has increased. However, the patient was started on Desidustat at this point of time. Around 1 month later, HB has increased to 9, and another 1 month later, the HB has increased to 9.5. However, unfortunately, the patient was lost to follow-up after that. Even they are, we tried to contact the dialysis center also, we couldn't get further updates regarding the patient status. Now, coming on to the discussion, pure red cell aplasia due to anti-EPO antibodies should be evaluated as a cause for refractory anemia. It occurs in a patient exposed to ESA for at least 8 weeks. There will be a decline in hemoglobin and increase in transfusion requirements. Normal platelet and white blood cell count and absolute reticulocyte count will be low. Now, how we evaluate and diagnose? Bone marrow aspirate shows severe erythroid hypoplasia with less than 5% red blood cell precursors. Platelet and white blood cell precursors are entirely known. Anti-EPO antibodies. Identification of antibodies to EPO is a critical component in diagnosis. Radioimmunoprecipitation assay, RIPA, is the most accurate test. However, it is not very commercially available. Enzyme-linked immunosorbent assays are widely available, but has appeared to have lower sensitivity and specificity. For the purpose of this patient, we have discussed it with the labs. Someone was told that Lalpath is doing this test. However, in the online, there is another lab called Litica Lab, which is based in, and there is the cost of this test is somewhere around 2,400 rupees. The treatment for PRCA, its initial management will be transfusions and discontinuing all recombinant erythropoietin products, including darbepoetin and epoetin alpha. Immunosuppressive therapy, various immunosuppressive therapies has been tried. Steroids alone in combination with cyclophosphamide, IVIG or plasmapheresis, cyclosporin, mycophenolate mofetil, and rituximab. Now, we could find some literature on HIF-PHI inhibitors on treatment of anti-EPO PRCA. There are few case reports on Desidustat. Desidustat has been treated has been used for treatment for anti-erythropoietin antibody-related PRCA in patients with ESRD. Now, what are the possible mechanisms by which HIF-PHI inhibitors lead on to improvement in anemia due to PRCA? We all know that HIF plays an important role in regulating B cell function, antibody response, and immune tolerance. HIF can negatively regulate B cells, preventing autoimmunity, and there will be reduction in antibody production. Another hypothesis is that the endogenous EPO produced by HIF-PHI contributes to neutralizing the anti-EPO antibodies, and it will not boost the production of new antibodies to EPO. Now, our case reveals the potential effect of Desidustat on anti-erythropoietin antibody-associated PRCA. Further studies are needed to assess its objective therapeutic effectiveness, adverse effects, and pathophysiological mechanisms. Thank you.